The problematic heel. Heel pain is something that we see incredibly common in clinic. The most common cause of heel pain would still be plantar fasciitis. It's the most common reason people would present, or they feel like they have plantar fasciitis. With 10% of the population having PF at some point in their lifetime, 80% of heel pain is attributed to PF. So like I say, it's probably the most common, and females being much more likely than males to suffer. There is often an absence of inflammation. So we tend to call it a fasciopathy rather than fasciitis, where itis is inflammatory. Fasciopathy is a condition of the fascia. It's considered an overuse condition, so it can be intrinsically linked to a fat pad, which sits very close to that area. The primary area of pain, as you can see on the diagram here, is kind of under the heel or in that medial border of the heel. Most cases are successfully treated conservatively in clinics. If not, there are a few different diagnoses that we're going to have a quick look at. Insertional Achilles tendinopathy is, as is shown in the red box here, a pain right on the back of the heel of the heel, sorry. It's always interesting when people present with heel pain as to what they consider their heel. Some people will point to the back, some people underneath, some people on that inner aspect. Insertional Achilles tendinopathy tends to have 3 stages, and it is a progressive condition. So we really want to get that looked at ASAP, really. Heel fat pad atrophy, as I've just touched on, can be intrinsically linked to something like plantar fasciitis. It's essentially a loss of shock absorption. So we have this fat pad that sits around the back and underneath of the heel here. It's usually progressive with age, so we would expect the person to be 40 years plus, and that fat pad can atrophy, so it kind of wastes away. It's nice and squidgy at some point, and offers lots of shock absorption. And then over time, as we age, it thins out, and that shock absorption becomes less. Some people will often say it feels like there's a stone under their heel when they walk. Calcaneal fractures are rare. Don't see too many of them, but they are out there. Generally, they would be a result of trauma. So landing heavy from a great height, for example, onto your heel, that might be a cause of a calcaneus fracture. Repetitive landing would put someone under that stress, which could lead to a potential stress fracture or stress response of a calcaneus, which in turn may lead to a calcanean fracture over time. Haglund's deformities are rare. They are sometimes visible, so sometimes we get this visible lump on the back of the heel. It's essentially where the bone has grown. There's been a bony morphology of the calcaneus, and it starts sort of pushing into the skin and the soft tissue. There might be some swelling, there might be a bump, there might be some redness. Sometimes it's visible, sometimes it's not. An X-ray might be needed. Often it's bilateral, so people will suffer both sides. It can come with or without retrocalcaneal bursitis. The bursa is this sac of fluid that sits between the bone and the tendon and the soft tissues, and acts as a shock absorber and allows things to move smoothly by each other, and that can become inflamed as well. It's actually, Haglund's are very poorly understood, really, and the cause can be multifactorial. No one's really sure 100% of what causes them, but it can be related to poor shoe fitting, a tight Achilles or soft tissue around the area, weak lower limb muscles. So if the calf complex isn't working optimally, it's been linked to someone with high arches, and unfortunately it can just be hereditary. There are various neurological conditions that could give you heel pain. So tarsal tunnel syndrome is compression of the tibial nerve as it passes through the tarsal tunnel, the tarsal tunnel is made up of your medial malleoli, which is what we would call your inner ankle bone, and the retinaculum, which is kind of like this soft tissue you can see on the image that comes across the nerve, acts like a seatbelt. It kind of keeps everything trapped down underneath, and if that becomes inflamed or irritated, that would give you heel pain or plantar pain, usually associated with numbness or tingling too. There could be a nerve entrapment, we call a Baxter's neuropathy. The Baxter's nerve is the terminal branch of the posterior tibial nerve, which can get trapped between the muscles and the soft tissues in the area, which again, a nerve entrapment would give you those signs and symptoms. Or it could be a radiculopathy, which usually comes from around S1 of the lower back. So if there's any back pathology or history of back pathology, that might be something we would look into as well. Inflammatory conditions, so something like rheumatoid arthritis, ankylosing spondylitis. Ankylosing spondylitis is an autoimmune condition which involves the spine. It's a form of arthritis, so that could cause referred pain down into that area. Or even something like gout, which gout is usually we would expect it to start on the big toe, but it's not unusual for it to be in the heel as well. It affects around 1 in 40 people. Like I say, most commonly it starts in the big toe with an ache and then becomes red, shiny, hot, painful, and generally you'd expect some level of feeling unwell as well. So having a fever, feeling hot, fatigue, often undiagnosed, and blood tests can be really helpful in ruling inflammatory conditions in or out. Calcaneal Apophysitis is what we used to call Sever's disease, and it is a adolescence condition. And you can see the ranges here, girls generally between 8 and 13, boys a little bit older. And it's to do with a damaged growth plate, which presents as heel pain. A squeeze test, so squeezing either side of the heel often elicits pain. Pain, stiffness early morning. Sometimes there's a compensation on the gait where children will start limping or toe walking. And it's considered a self-limiting condition where the pain dominates or allows the child to do as much as they can within their pain tolerance. There is a strong correlation with heel pain and footwear, in that the more minimalist footwear someone wears, the more likely they are to have a plantar or foot pain, whereas the more conventional or cushioned, more likely to have a knee style pain. And training, again, particularly for runners, running pace, the faster you run, the more plantar foot pain we see, whereas the higher the volume, the more knee pain. Most conditions, the initial protocol would be the P.O.L.I.C.E protocol, so protect, optimal loading, ice, compress, elevate. There's a question mark behind compress, because if the condition is considered a compressive condition, and some of these are, we wouldn't look to compress it necessarily. Optimal loading is probably the most important still for me. We replace rest with a balanced and incremental rehabilitation, which we could guide you through here. So I hope that's been useful. If so, let us know. Feel free to ask as many questions as you want. Thank you for watching.